Okay. Good morning. As part of our series of lectures from recent advance in surgery, today we will have a discussion on fluid and electrolyte balance in surgical patients. Dr. Arkaprovo, who is assistant professor of surgery at Calcutta Medical College, will deliver this lecture on this fluid electrolyte balance. It's a very important topic, not only for examination but for your day-to-day practice. It's a very important topic, and there has been a lot of changes in management of patient in the point of view of fluid electrolyte management. So Dr. Arkaprovo will take us through this topic for next 1 hour. Dr. Arkaprovo, you can please start.
Thank you, sir, and good morning, everybody. Yes, this is a very good topic, and it is a very important topic to be understand for the day-to-day practice. And most of us are lacking behind the knowledge of how to manage the patients post-operatively regarding fluid and electrolyte balance. And so, in this era of ongoing identification and analysis of medical errors, fluid and electrolyte management has trailed behind. So, it is, and with the advent of ERAS protocol, it has become more and more important to manage fluid and electrolyte in post-surgical patients, mainly in gastrosurgical patients. Now, why? So a brief introduction, human cell consists of 65 to 90% of water. Specific fluid and electrolyte concentrations are necessary in order to maintain cellular metabolism. And protocol orders, which is already set, is actually allow for one size fits all, which is not very good because it may not optimize patient recovery and may be detrimental in time. So whatever we're using in the earlier days, like yes, eringal lactate is to DNS 1:2 or anything other protocol, that is not good for every patient. Now, what is meant for resuscitation of fluids? It is meant to replace large volumes of fluid in all compartments. Goal is plasma volume expansion to maintain or regain adequate perfusion to enable optimal organ function via oxygen delivery. So why this resuscitation needed? So again, resuscitation is needed actually in trauma patient, in preoperative phases, and sometime in postoperative phases of major operations. So hypovolemia and decreased tissue oxygenation causes anaerobic metabolism, which causes increased production of lactic acid. Now, this persistent tissue hypoxia causes buffering ability to be overwhelmed, leading to lactic acidosis. Now, we should know, what does acidosis do? It reduces the activity of extrinsic and intrinsic coagulation pathways and diminishes platelet function. Acidosis speeds the progression to coagulopathy and organ failure. Now, what has to be achieved? So goal-directed resuscitation therapy aims to correct physiologically and clinically relevant parameters to specific endpoints. So traditional endpoints are systolic blood pressure should be more than 120 millimeter of mercury, or mean arterial pressure of more than equal to 70 millimeter of mercury. Urine output should be 0.5 ml per kg per hour. Base deficit should be less than 2, or lactic acid less than 2.5. And always avoid over resuscitation. Now, there is a study that early goal-directed therapy for sepsis is described by Rivers and colleagues involves infusion of crystalloid to a central venous pressure of 14 millimeter mercury to augment tissue oxygen delivery. Next come maintenance fluid. Its goal is to provide water, electrolytes, and to lesser extent calories. Fluid of choice is dextrose, and it should be administered at the rate of 35 to 50 ml per kg body weight per day. With this, we have to note some important points which have come up in different studies, and ultimately it has been accumulated and jot down in one particular framework, that enhanced recovery program aim to implement multimodal pathways in the perioperative period to reduce the risk of perioperative organ dysfunction and morbidity through such aims as encouraging early mobilization. Overall goal of fluid management should be to maintain euvolemia while avoiding excess water, salt, and electrolyte imbalance. Because of the risk of inducing hyperchloremic acidosis in routine practice, when crystalloid resuscitation or replacement is indicated, balanced salt solutions, example, Ringer's lactate or acetate, should replace 0.9% saline, except in cases of hypochloremia, like from vomiting or gastric drainage. Solutions such as 4% dextrose saline or 5% dextrose are important sources of free water for maintenance, but should be used with caution as excessive amounts may cause dangerous hyponatremia, especially in children and the elderly. These solutions are not appropriate for resuscitation or replacement therapy except in conditions of significant free water deficit like diabetes insipidus. To meet maintenance requirement, adult patients should receive sodium 50 to 100 millimole per day, potassium 40 to 80 millimole per day in 1.5 to 2.5 liters of water that can be delivered by oral, enteral, or parenteral route, or combination of these. Additional amounts should only be given to correct deficit or continuing losses. Careful monitoring should be undertaken using clinical examination, fluid balance charts, and regular weighing when possible. When patients leave theater for the ward, HDU or ICU, their volume status should be assessed. The volume and type of fluids given perioperatively should be reviewed and compared with fluid losses in theater, including urine and insensible losses. In patients who are euvolemic and hemodynamic stable, a return to oral fluid administration should be achieved as soon as possible. In patients requiring continuing IV maintenance fluids, this should be sodium poor and low enough volume until the patient has returned their sodium and fluid balance over the perioperative period to 0. When this has been achieved, the IV fluid volume and content should be those required for daily maintenance. The hemodynamic and fluid status of those patients who fail to excrete their perioperative sodium load, and especially whose urine sodium concentration is less than 20 millimole per liter, should be reviewed. In patients who are edematous, hypovolemia present must be treated, followed by a gradual persistent negative sodium and water balance based on urine sodium concentration or excretion. Plasma potassium concentration should be monitored, and where necessary, potassium intake adjusted. Now, this is the typical adult baseline electrolyte requirements. There are sodium, potassium, calcium, magnesium, phosphate, and chloride. Sodium should be at the rate of 135 to 145 millimole per liter. Daily requirements 1 to 2 milliequivalent per kg body weight. Potassium is 3.5 to 5 millimole per liter. Daily requirements 0.7 to 0.9 millimole per kg. Calcium chloride 7.6 to 10.8 milligram per dl. Magnesium 1.5 to 2.5 millimole per liter. Both calcium and magnesium requirement increases in case of pregnant females. Phosphate is 2.4 to 4.5 milli per liter. Chloride is 98 to 108 millimole per liter. These are the basic electrolytes that are required for cellular function, and that should be maintained properly in postoperative period. Now, we should take up the different electrolytes one by one. So first, disorder of sodium balance. The first important thing is dilutional hyponatremia. It is the most common inpatient disorder of sodium balance. A decrease in sodium generally indicates free water excess rather than a true total body sodium deficit. In general, those with dilutional hyponatremia have a normal or nearly normal plasma chloride and a high urinary sodium as well. The therapy for this disorder is fluid restriction to decrease free water, not the delivery of a higher sodium content fluid. Judicious diuretic use may also help correct dilutional hyponatremia. Next comes salt depletion hyponatremia. True total body salt depletion leading to hyponatremia is less common than dilutional hyponatremia. However, this disorder is more common in those on chronic diuretic therapy coupled with a salt-restricted diet. Therapy is the provision of additional salt by the intravenous or oral route or both. The following formula may be used to estimate the anticipated change in serum sodium when correcting hyponatremia using intravenous fluids. That is, sodium load equal to infused sodium plus infused potassium minus serum sodium divided by total body water plus 1. This is as a whole. This formula can also be applied for a total fluid and electrolyte balance. So some correction factor may be needed that I am talking later on. Next comes hypernatremia. Hypernatremia is a disorder of water metabolism, not of sodium hemostasis. As such, the sodium as in high amount, that is more than 145 milliequivalent per liter, is secondary to a free water deficit. Like hyponatremia, hypernatremia is divided into acute or chronic states with 48 hours as the dividing time. Some general rules to be applied for the safe correction of symptomatic hypernatremia. Correct no more rapidly than 1 to 2 milliequivalent per liter per hour. Provide 50% of the water deficit in the first 12 to 24 hours and the rest over the next 24 hours. So we should not correct the hypernatremia in a day also. We should take 2 to 3 days to correct the hypernatremia. Measure electrolytes every 2 hours during correction to adjust the rate of correction to avoid cerebral edema. Asymptomatic chronic hypernatremia should be corrected at a rate not exceeding 0.5 milliequivalent per liter per hour and not greater than 10 milliequivalent per liter over 24 hours. These are things to be monitored, but it is very difficult to calculate in general ward. So it is better to treat the patient in ICU or HDU with proper infusion pump. Again, the same formula can be applied to correct the sodium load, that is sodium is equal to infused sodium plus infused potassium minus serum sodium by total body water plus 1, where total body water is estimated as 5 kgs. Now these factors, there's some correction factor, that is the variability. So in children, you have to multiply with 0.6. Now in elderly men, it is again 0.6. In women, it is 0.5. In elderly men, it is 0.5 and elderly 0.45. The total equation has to be multiplied by these factors so that to have a correct measurement or near correct measurement of sodium need. Next comes very important thing is disorders of potassium balance. These are very important and very common one. So first of all, it is hypokalemia. Hypokalemia is much more common than hyperkalemia in hospitalized patients. In those with normal renal function, hypokalemia is often related to diminished intake, the infusion of potassium-free fluids, or the use of caliuretic diuretics, that is loop diuretics such as furosemide. It is important to recall that serum potassium deficit does not demonstrate linearity with amount needs to restore a normal concentration when the measured potassium is less than 0.3 milliequivalent per liter. Thus, a total body deficit exists when serum potassium is less than 3 milligram per liter, and patients generally require 200 milligram potassium and often more to replace intracellular and extracellular potassium to normal, especially in the setting of ongoing renal or GI losses. An acute and potentially life-threatening dysrhythmias are common with potassium less than 3 milligram per liter, and the concentration of the replacement solutions is typically higher than may be administered on the general ward. Continuous electrographic monitoring is required, as is central access to avoid venosclerosis and tissue injury. In addition, restoration of normocalemia relies on the establishment of normomagnesemia, as both potassium and magnesium co-transport in the kidney. So you have to be very prudent and very cautious in detecting these features of hyponatremia, hypokalemia, because those are always coexisting. That hypokalemia, hyponatremia be coexisting and can be can come separately also, and you have to see the patients very carefully and also assess the patient clinically for hyponatremia and hyperkalemia. Patient may be confused, patient may be lethargic, patient may be not showing any response to your comments, and also some neurological problem can develop, and you can very well land up with confusing that patient is having some neurological disorder. Even the hypokalemic and hyponatremic patient may reveal some features like CV also. So these things can be very promptly and aptly tackled by seeing the clinical features and also some parameters of the patient. Next come hyperkalemia. Therapy for hyperkalemia depends on achieving three goals: reducing plasma concentration, preservation of myocardial conduction, and reduction of total body potassium. The specific therapy undertaken depends in part of renal function, the ability to tolerate plasma volume expansion, and the degree of hyperkalemia. Though often cited as a cause of hyperkalemia in those with renal dysfunction, infusion of ringer lactate with approximately 4 milliequivalent potassium per liter should not cause hyperkalemia. So this is the standard regime which should be followed post-operatively for first 6 to 12 hours after proper measurement of potassium. Exogenous potassium administration should be stopped once you have achieved the potassium concentration to desired value. Now, you can, if it is not achieved, 10% calcium gluconate or chloride, 10 to 20 ml over 15 to 30 minutes, or 1 liter of intravenous fluid can lower the serum potassium and suppress the myocardial effects of hyperkalemia. Urinary volume and excretion of potassium is promoted by rapid infusion of 5% glucose, which ultimately stimulates the release of insulin. In addition, insulin 1 unit per 5 gram of glucose is recommended. Alkalization of extracellular fluid with sodium lactate or bicarbonate promotes transfer of potassium into cells. This is absolutely necessary when hyperkalemia is associated with metabolic acidosis. The above maneuver are temporary given adequate time of removal of excess sodium by cationic exchange resins and peritoneal dialysis or hemodialysis. When associated with oliguria, urine output may be increased by infusion of hypertonic saline solution, 50 gram of insulin, 1 liter solution, later cation exchange resins, and dialysis is considered. Next come hypomagnesemia. Often it is overlooked, but may persist as a cofactor for hypokalemia, and its coexistence with hypokalemia should be raised in mind, seeing the patient not improving with the only administration of potassium. So it is best treated by IV magnesium chloride and magnesium sulfate solution. 2 milliequivalent of magnesium per kg per day. Avoid magnesium toxicity. Monitor heart rate. respiration and ECG. Toxicity may lead to cardiac arrest. Calcium chloride or calcium glucone is kept in hand if there is any adverse effect. Continuous replacement over 1 to 3 weeks is necessary. 10 to 20 milligram 50% magnesium sulfate daily by IM or IV route can be given. Next come hypocalcemia. Hypocalcemia is also not very common, but can be associated with some operations like total thyroidectomy and operation on parathyroid. So the features of hypocalcemia is very clearly, can be very clearly delineated by carpopedal spasm and also oral spasm of oral muscles and also twitching of muscles. So you should administer IV calcium gluconate or chloride, calcium lactate orally with supplement of vitamin D3. Patient receiving blood transfusion do not require calcium supplementation. The binding of ionized calcium by citrate is generally compensated by mobilization of calcium by body stores. But if blood is given as rapid as 100 ml per minute, calcium may be indicated. Oral or inorganic phosphates can lower the calcium level by inhibiting bone resorption and forming calcium phosphate complexes that deposited in soft tissue and bones. IV administration may reduce the calcium abruptly, but there is a fear of tetany, hypotension, and acute renal failure. So it gives very slowly over a period of 12 hours and once daily and not more than 2 to 3 days. Corticosteroids can decrease resorption of calcium from bone and reduce intestinal absorption of vitamin D3. Now, though it is not written over here, hypocalcemia, hyponatremia, and hypokalemia, along with that, hypochloremia is most of the time present. So it can be actually due to extrarenal or renal abnormalities in chloride intake or losses or from changes in volume of total body water. Extrarenal causes included decreased sodium chloride intake, GI losses such as emesis, nasogastric drainage or diarrhea or skin losses as in severe burns. In these instances of depletion of total body chloride, extracellular fluid compartment contraction occurs with subsequent hypotension, tachycardia, and orthostasis. Urine studies will reveal decreased sodium and chloride. Now, in these cases, we can administer hypertonic sodium chloride solution, potassium chloride supplements, or in severe cases, hydrochloric acid can also be used, though it is very rare. So in these cases, we should correct hypochloremia because it is associated with severe metabolic acidosis, alkalosis, which is generally chloride responsive. So if we see that there is metabolic alkalosis, we should always think of hypochloremia. So hypochloremia is a thing which is often missed out, but usually, though very rare, but usually associated with other electrolyte imbalances. Next comes hypercalcemia. So particularly useful in treating patients with sarcoidosis, myelomas, lymphomas, and leukemia. Calcitonin can also reduce serum calcium level. Mitramycin can also lower the calcium level in 1 to 2 days. IV furosemide may also reduce calcium level by increasing urine output. Definite treatment in hyperparathyroidism is surgery. Now, apart from these electrolytes, there is also hypophosphatemia, hyperphosphatemia, hyperchloremia. So again, hyperchloremia can lead to metabolic acidosis, and we should correct hyperkalemia. And it is though rare in comparison with hypernatremia, hyperkalemia. So again, hyperchloremia if present, we should give sodium bicarbonate to correct the metabolic acidosis. So Fluid and electrolyte goals and deficiencies must be defined for individual patients to provide the appropriate combination of resuscitation and maintenance fluids. Specific electrolyte abnormalities uh, should be anticipated, identified, and corrected to optimize organ fraction. Now, last sentence, using the strong an approach to acid-base assessment, delivered fluids that contain calculated amounts of electrolytes will interact with the patient's plasma charge and influence the patient's pH, allowing us to achieve a more precise endpoint. Now, this presentation I'm ending here, but I am switching to another presentation where I am talking about something about acid-base balance, because without the discussion on acid-base balance, the water electrolyte management part cannot be fulfilled. So please bear for a few minutes. Okay, so now I am starting with acid-base balance, though it is a big topic, but I am just going through the basic points. So in a healthy individual, pH of the body fluid is normally maintained within narrow limit in spite of large load of acid produced endogenously as a byproduct of body metabolism. Normal range is 7.35 to 7.42, and this is the equation. pH is equal to pH plus log of bicarbonate by 0.03 into PCO2. The value of pK being 6.1. Now, then come acidosis. It is first is metabolic acidosis. In this condition, there is a gain or retention of fixed acid or loss of base, mainly bicarbonate. I am not going to the details of the causes. There are diabetic acidosis, lactic acid azotemia. That if the pH level goes down to 7.1, it is serious. Clinical features: initial compensation of metabolic acidosis is pulmonary with increased the rate and depth of breathing, depressed the arterial PCO2 level, overbreathing eliminates CO2, respiratory may rise up to 50 per minute, urine becomes strongly acidic, pulse is tachycardia, and with BP initially high, then it's lowering down. Treatment. So initially you should go for IV ringer lactate along with sodium bicarbonate. Treat dehydration with normal saline. Sodium bicarbonate should be given 4.2% solution which contain 0.5 milligram bicarbonate level. Now, if it does not subside, then we have to go for infusion of bicarbonate along with thinking of ventilator support, because this type of patient can very well go to cardiac arrest. Now, next come respiratory acidosis, less common than metabolic type and mainly caused by interference with gaseous exchange in the lungs, leads to CO2 retention. Now, here causes are anesthetized patients with too much relaxants may be unable to start proper ventilation for quite a long time. Lung disorders like emphysema, bronchopneumonia, chronic bronchitis, and pulmonary edema. Crushing or other injuries to chest, peritonitis, brain injury leads to depressed respiratory center, poisoning with alcohol, barbiturates, morphine, airway obstruction. Now, again, clinical features depend on the cause and degree to which compensation is effective. During anesthesia, there may be slow rise of systolic and diastolic BP. In most cases, respiration is abnormal, restlessness, hypertension, tachycardia are sign of poor ventilation. Treatment. First, you have to treat the pulmonary defect. Adequate ventilation is needed. Endotracheal intubation, mechanical ventilation, encouragement of deep breathing, coughing, using humidifier air to prevent of secretion. Oversedation or overuse of muscle relaxant should be avoided. Next come alkalosis. First is metabolic alkalosis. Both pH and plasma bicarbonate concentration are elevated due to loss of fixed acid or gain of base. Majority patient associated with hypokalemia. Depletion of cellular potassium results in entry of hydrogen and sodium ions into the cells, leads to lowering the intracellular pH and extracellular alkalosis. Excessive urinary potassium loss in exchange for sodium, which further accentuates alkalosis. So state of hypokalemic metabolic alkalosis results. Again, causes are well known: excessive ingestion or absorption of alkali, patients vomiting in pyloric obstruction or continuous gastric aspiration. To compensate for alkalosis, there is reduction in respiratory exchange due to inhibition of respiratory center by raised pH leads to accumulation of CO2 and carbonic acid to lower the pH. Now, clinical features. Mild degree of alkalosis does not cause any symptoms, only recognized by raised plasma bicarbonate level. Most striking feature is the phasic respiration. Period of apnea of 30 seconds or more, followed by an onset of respiration, which is first shallow and then increase in depth until the excursion is normal. After 2 to 3 respiration of normal range, it again declines to apnea. Tetany may occur in severe cases. Latent tetany is more common. Increased irritability of skeletal muscle. Treatment is main thing is to remove the cause, maintain an adequate volume of blood, bring down alkalosis by giving ammonium chloride. Potassium depletion may go hand in hand with metabolic alkalosis, so infusion of potassium chloride is also necessary after proper measurement of potassium. Next come respiratory alkalosis, mainly caused by hyperventilation, reduce the tension of carbon dioxide in the alveolar air and hence the plasma, so extracellular carbonic acid concentration falls and the pH rises. What are the causes in surgical practice? During anesthesia, when excessive manual pulmonary ventilation is executed with use of muscle relaxant, due apprehension, pain or injury to CNS due to hysteria, high altitude and dry atmospheres, high fever, and others also. Arterial CO2 should not allow to fall below 30 millibar mercury. Complication may occur in presence of complicating hypokalemia, depends on increased renal excretion of bicarbonate. If associated with hypokalemia, ventricular arrhythmia and fibrillation takes place. Clinical features are very vague and suspicion is the main criteria for diagnosis. There may be pallor, hypotension. In both acidosis and alkalosis of respiratory origin, there is some risk of respiratory arrest when disturbance is severe. Treatment is frequent blood gas analysis and adjust ventilatory pattern, correct potassium deficit. If respiratory arrest occur, immediately corrected by insufflation of CO2. Now, this is the laboratory feature, that is where acidosis, metabolic acidosis compensated. This is the features of is reduced, plasma CO2 reduced, plasma pH also reduced. And also in case of respiratory acidity, just the opposite, but plasma pH is increased. Also alkalosis, and so normal value you should remember, bicarbonate value you should remember, and PCO2 should be remembered. So with all the things to remember, 2 to 3 things should be on the tip. That is, what is the actual or normal value of bicarbonate, PCO2, and we should always look for hypokalemia. In any of these cases, hypokalemia is the most common and most dangerous things in case of water electrolyte management, in terms of post-operative patients of surgery, in case of mainly gastroenterology surgery, because if it is go unnoticed, though it is very easy to tackle, but if go unnoticed, many problems can occur. Now the last one is anion gap. The anion gap is a measure of acid-base balance. The anion gap is the difference between the number of cations versus anions. An anion gap can high, normal, or low. A high anion gap indicates the presence of more anions than cations or acidosis. When bicarbonate is used up to correct the acid-base balance, the gap widens. Normal anion gap metabolic acidosis is also called hyperchloremic acidosis because the kidneys can reabsorb chloride instead of reabsorbing bicarbonate. The normal value for the serum anion gap is approximately 3 to 10 milligram per liter. We know average is 6 milligram per liter. Remember what when calculating the anion gap, the CO2 value from a patient's basic metabolic rate is often used as an equivalent value for the bicarbonate from an arterial blood gas. The total CO2 content includes the serum bicarbonate as well as available forms of carbon dioxide, and the serum bicarbonate comprises about 95% total CO2 content. Therefore, it is common to use this measurement to estimate the serum bicarbonate level. High anion gap may be caused by ketoacidosis, lactic acidosis, renal failure, and toxic ingestion. Normal anion gap is due to gastrointestinal or renal bicarbonate losses and impaired renal excretion. Signs and symptoms include nausea, vomiting, malaise, hyperapnea, fatigue, cardiac dysfunction. Diagnosis. The cause of high anion gap acidosis may be obvious, as in diabetic ketoacidosis, hypovolemic shock, or missed hemodialysis. Other data that is helpful is ABG, serum electrolytes, lactate, and possible toxins. Elevation in anion gap indicates a metabolic acidosis, a normal anion gap with a low bicarbonate, and a high serum chloride indicates a non-anion gap metabolic acidosis. If a high anion gap acidosis is present, a delta ratio is calculated to help determine its cause. And there are other formulas also. This is a delta ratio, that is delta anion gap by delta bicarbonate is equal to Ag, that is arterial gas minus 12 divided by 25 minus bicarbonate. And also in this formula like this, PCO2 is equal to 1.5 into HCO3 plus 8 plus minus 2. So these are the two formulas to calculate the anion gap and to treat. Treatment is directed at reversing the underlying cause. Hemodialysis is required for renal failure and sometimes for ethylene glycol, methanol, and salicylate poisoning. When metabolic acidosis results from loss of bicarbonate, as in normal anion gap acidosis, bicarbonate therapy is usually safe and effective. However, treatment with sodium bicarbonate for high anion gap acidosis is controversial. Is typically used only in case of severe metabolic acidosis when the bicarbonate is very low and the pH is below 7.1. So with this, I am concluding my topic, though it is very difficult for a surgeon to culminate all the things of electrolyte water balance and acid-base balance, and is rather easier for the anesthetist people to make understand of these things. So I'm concluding my topic.
Okay. Thank you, Orko, for a nice presentation of different fluid electrolyte disturbances and their correction. But point is, in surgical patient, there are some specific scenarios. Often there is a question in the exam, perioperative fluid management. So if that is a scenario, perioperative fluid management, that perioperative includes preoperative, intraoperative, and postoperative. So the preoperative fluid management is based on the existing deficit, as you already talked, that you should evaluate the patient, find the electrolytes level and the volume status, and replace. Intraoperative is with the anesthetist, and there are some guidelines to provide intraoperative fluid therapy. That means anesthetist replace what? They will replace the maintenance volume for this period of surgery, maybe 1 or 2 hours, whatever, And second is most important, the anesthetist is they should assess the amount of blood loss coming up during the surgery. And if the blood loss is less than 15% of total blood volume, blood need not be replaced. But that amount of blood that is being lost should be replaced by 3 times the crystalloids. And you have talked about the post-op fluid management. That means you have to take into account the intraoperative loss, the pre-op deficit, and the post-op. And a lot of controversy comes in the post-op fluid management. I find many people giving normal saline is to RL 1:1 4 hourly. People does not think how much sodium he is pumping. The most important part for management of post-op fluid management is twofold. One is one has to consider that these are the patients who require some basic calorie for maintenance of cerebral, cardiac, renal, and respiratory function. And it is established that a post-op patient should receive at least 100 grams of dextrose to maintain these basic metabolic functions. And on an average, a body requires about 400 kilocalorie of energy for this basic metabolic function. So one has to give the patient at least 100 grams of dextrose. Second is, in the immediate post-op period, in view of endocrine and the stress response, all the hormones in the body increase. And the net effect of this is there is retention of sodium in the body. In view of tissue injury, there is some release of potassium from these dead cells. So in initial 24 to 48 hours, patient may require less sodium, less potassium based on their daily requirement. So you should not pump more sodium and potassium in the immediate post-op period. And this should be guided by a proper evaluation of the serum electrolytes level, and this should be guided by weighing the patient. So these are the basic principles. And we have talked about there are different ways to maintain the fluid balance in surgical patient. One is a concept called zero fluid balance. That means we take into account the patient output. Maybe we are charting fluid in the first post-op day. We take the account the urine output, Rayleigh tube output, any drain output, and the insensible loss. And you chart the fluid for the next 24 hours based on this output, making a zero balance. That is zero balance fluid therapy. This zero balance fluid therapy is not always effective because there are a lot of factors which can affect this fluid balance. So now the more accepted form of fluid therapy is described as goal-directed fluid therapy, whereas Dr. Arkaprovo has talked clearly. That means these are the patients who are critically ill, require intensive fluid management. One has to go by the vital parameters like either CBP or pulmonary capillary wedge pressure. You have to maintain the urine output and the biochemical parameters. So goal-directed fluid therapy is a more important way of monitoring and replacing fluid replacement. Dr. Maiti, any comment?
Sir, one thing I am just telling you.
Yeah.
The recent guidelines, the most accepted guideline is NICE guideline. Anyone can go to the internet and can click the NICE guideline and can see it. And also the ERAS protocol.
Yeah. Any question? Yes, Dr. Maiti.
Thank you, Professor Saha and Dr. Arkaprovo. And really the understanding the fluid electrolyte and acid-base balance is very difficult as well as very much necessary for all the clinicians, particularly the surgeons in the post-operative period. Till we have to learn, for me, I have to learn more because there are so many difficult parts in understanding it, and until and unless we have the proper way of monitoring the patient, it will be very difficult to manage, and particularly the calculation part. The mathematical calculation formula, most of the time probably not followed by the clinician. It is the clinical methods and the improvement and response of the patient to the treatment given by the proper replacement is particularly observed. For the postgraduates, some important clinical features I like to mention about the hypokalemia. The prostration, that is the patient is becoming drowsy, not responding properly in spite of maintaining the blood pressure, pulse, etc. Gradually going down on it is more response, and also there is arrhythmia. In that case, we must suspect hypokalemia. And replacement of the potassium should be very cautious. It should not be very rapid. It should not be overemphasized. And if possible, instead of IV, when the patient can take orally, then orally the potassium replacement should be given. Regarding the sodium deficiency or hypersodium, hypernatremia, in both the cases probably convulsion is one of the important feature. So when a patient, in postoperative patient, is having convulsion, we should think both in the as a cause, that is hypo and hypernatremia may be the cause of convulsion. So that few points regarding the acid-base balance, all those things are very critical, and the ICU management may be needed in a critical patient. But for the general purpose, particularly, we should be very careful about the sodium, potassium, and the water itself. When the patient is also having the other metabolic problems like diabetes, jaundice, pyloric stenosis, in those cases, as Professor Saha or Arkaprovo has particularly mentioned, in those cases particularly we are very careful, and we should balance the other important parameters. For example, in case of renal failure, there is always some problem. In case of congestive heart failure, we should be careful about the water retention. Okay, thank you. These things, and there are so many things. I think Dr. Saha and Dr. Arkaprovo, you can organize another session where you take particularly a case-oriented discussion. In practically after a case in the clinical methods, and a case how he is improving, or how whether there is a deterioration in the postoperative course, that will give more impact to the student.
Right. Any question in the chat box, Milind? Any question in the chat box?
No, sir, there are no questions, sir. Actually, sir, some in the OSCE now there are some so there are some scenarios that are given, and so some students wanted if you could tell us how to approach these scenarios, sir. One of them is, for example, a 25-year-old male brought to the emergency with history of motor vehicle accident, GCS 9/15, patient unconscious. On examination, pale, thready pulse with cold extremities, BP is 80. Which is the ideal IV fluid for this patient? So these are some of the questions that come in the OSCE.
Yes. Dr. Arko, would you like to answer?
This is rather a protocol based. It is actually rather you should go by ATLS protocol, ABCD. You should first and the best fluid in this case is till date again either ringal lactate or normal saline first.
And volume? This is a situation of hypotension following rotary accident. That patient has got blood loss. So initially at the beginning you cannot give blood. So initial fluid is crystalloid, either normal saline or ringal lactate solution. Challenge is with a 500 to 1 liter of fluid, and then reassess.
So
and
if they are asking,
so
if they are asking something like which is the ideal IV fluid, so should we mention broadly crystalloid, colloid, or should we go for a specific IV fluid? So that should be the answer rather than NS or RL, or should we specify NS or RL?
Either normal saline or ringal lactate solution, 500 to 1 liter, and then reassess the response. Three things can happen. Patient has responded, BP has come up, patient has responded, but after half an hour, 1 hour, again going down. And third is, with this fluid challenge, patient has not shown any improvement. So there are three groups of patient and three implications. If the patient has responded and maintaining, that means patient has a loss which has been managed by this fluid resuscitation. Patient should be on maintenance fluid. Second group of patient means that patient has responded but is showing a decline. That means these are the patient who has got continuing blood loss, which should be addressed. And third group of patient where the patient is showing refractory shock, the other patient, they have massive loss and continuing loss, which
More than
needs to
30
be evaluated and addressed. And now the concept has changed in acute setting. In acute setting, high volume crystalline resuscitation is not advisable. They're now telling that once you have managed in emergency for about 1 or 2 hours, if the patient has continuing blood loss, the ideal resuscitating fluid will be 1:1:1 of fresh frozen plasma, RBC, and platelets. That is the ideal resuscitation fluid when the patient has got massive blood loss. We call that as massive transfusion. That is the concept coming up now for resuscitation of patients who are in emergency coming with blood loss.
Okay, sir.
What Sarah has told, the recent volume of recent edition of Washington Manual, this protocol has been written very, very nicely. We can go through that.
Okay, sir. Thank you, sir.
Shall I leave?
Yeah, Dr. Arko, thank you very much. Thank you very much.
sir.
We have an idea about the different electrolyte imbalance, and one should keep, most of the time people are in diabetic patients. People are feeling that diabetic patients should not be given dextrose. That is a very wrong idea. Once the blood sugar is less than 250 mg/%, these are the patients who should always receive dextrose, because we require dextrose for the basic metabolic function. There is no contraindication of giving dextrose to the patient who is diabetic, except situation that sugar is more than 350 or 400, where you should treat in the line of diabetic ketoacidosis and bring the sugar to the level of 200, 250, and then come with the maintenance dextrose. Okay, thank you very much, Dr. Arko.
Thank you, sir.
Thank all the participants. I will continue with the online classes because the Omicron crisis is getting worse. So we are totally online now. Thank you very much. Thank you.
Thank you, sir.
Yeah, Deepak.
Good morning, sir.
Yeah.
Sir, one question.
Yes.
Sir, actually, in those type of OSCEs, they are also asking for some kind of how will you give the nutrition to the patient, post-op patient, like that.
Yeah.
They are asking how will you give the fluid, how will you give how much amount of fluid, how much amount of nutrition, like that they are asking.
Yeah. Okay. We'll have another session on nutrition. I try to understand.
Okay, sir.
Suppose we are doing a cholecystectomy.
Yes, sir.
We are not concerned about nutrition because these are the patients who are nutritionally preserved. They're coming up for surgery. Within 6, 8, 10, 12 hours, he is back to oral diet. So we are not concerned about nutrition.
Yes, sir.
Unless patient has got gross pre-op deficit.
Yes.
We are concerned about nutrition when the patient has got pre-op deficit, like CS stomach, patient is vomiting, patient having a underlying malignancy, patient is already wasted. So here the nutritional management is very important because your outcome of surgery will be decided by this patient nutritional status. So in these patients, one important aspect of management is preoperative nutritional assessment. And there are number of parameters to say whether the patient is having good nutrition, patient is having a poor nutrition. If patient is nutritionally poor, he should correct the nutritional abnormalities before going for surgery. Patient has low albumin. The concept is not that you give albumin and take the patient for surgery. Patient has low albumin means patient has global nutritional deficit. So in that case, instead of correcting only the albumin, you should give the patient a good amount of global nutritional elements. If he is tolerating orally, give oral. If not oral, either give enteral or intravenous. Number one. Number two, in the post-op period, in the immediate post-op period, if the patient will be fasting for 2 to 3 days, it is said the body store can make up the energy requirement for initial 2 to 3 days if the patient was nutritionally maintained in the pre-op phase. If patient has pre-op nutritional deficit, we should think of giving the patient nutritional support from the immediate post-op period. So what nutritional support you can give in the immediate post-op period, that has to be given intravenously. And you have all the preparations available in the market. You have dextrose, you have fat emulsions, you have proteins in the form of amino acid infusion. So you have to calculate. You have to calculate how much calorie you like to give to this patient, and based on this, you calculate that 70 to 80% of the calories should come from carbohydrates, and 20% to 30% calories should come from fat consumption. And don't calculate the protein you are giving to the tune of 1 to 2 gram per kg body weight will not come for calorie calculation, because protein is required for healing, for bodybuilding. So you calculate how much calorie you like to give. From that, suppose you need to give 1500 kilocalorie. So 70% will be 1000 kilocalories should come from carbohydrate. Dextrose, you are replacing 1000 kilocalorie. Now we are trying to give the patient 500 kilocalorie from fat. So you give the patient around 60 grams of fat. This will deliver you another 500 kilocalorie of energy. And then you should add up with 1 to 2 grams of protein, which will not be calculated for calorie requirement, that is required for the patient bodybuilding and healing of the operative area. So these are the considerations in nutrition management of a pre-op and post-op patients. Okay, there are a lot of things you should read. How do you allocate calories? How do you divide calories in different food preparation? Now you have the advantage. We have all things mixed in a bag. You just can calculate the bag amount required.
Thank you, sir. Thank you, sir. Sir, if possible, sir, please take a class on this.
Yeah, we will take. This series of lectures will continue.
Okay, sir. Thank you, sir.
We'll cover the basic aspects of surgical part, which comes in exam. This will be in the form of faculty lectures. We have some session on seminar by the students also, but we'll keep some topic on faculty lecture. But in fluid electrolyte, I also wanted to have a clear concept of normal balance in the body, how you decide about the intake based on the output, and the most important part, which has not been discussed today, is perioperative fluid management. That is a very important question that comes up in the Indian examination. How do you plan perioperative fluid therapy? So that will include pre-op, intra-op, and post-op fluid management. Okay.
And
Okay, sir. Thank you, sir.
Professor
Yeah.
Saha,
Yes.
if you organize any next discussion, also include the pediatric surgical patient. A special consideration should also be given to the pediatric surgical patients. Okay, regarding their fluid electrolyte balance. And for the PG, I must mention also your stethoscope should be very active to auscultate the lung, because any fluid electrolyte balance overhydration should always be dangerous, and you should calculate, and whatever may be the formula, you should be also guided by your auscultatory finding whether any clefts appear in the lung or not. So in that situation, you should restrict the amount of fluid also.
Okay. Thank you. Thank you all.
Thank you, sir.
Thank you.